what I did the last minutes and hours is looking to the clock and realizing that the time is going by, so we are about 1 hour behind our schedule. So what I did is cutting down from 31 slides to 18 slides, and now I'm down to probably 11 slides for the introduction. So any question on that one? The next thing is only I can disappear. So, but probably it is a short introduction into non-invasive ventilation, and as it is titled, Why Do Patients Fail Non-Invasive Ventilation? And just to remind you, the goals of mechanical ventilation are once to reverse the failure or to support the muscular pump, which is failing, which is leading to alveolar hypoventilation, and thus to hypercapnia. So that's the left side. So the hypercapnic leading respiratory failure, while if you look on the right side is lung failure, where you have the instability of the alveolar gas space, and in that case you have a loss of FRC and compliance, and you need to apply a positive airway pressure in order to stabilize the alveolar space. So that's the goal of mechanical ventilation. And if we look for invasive versus non-invasive ventilation, they are equally effective, basically. And that has been nicely shown here by Whitaker in 2001, comparing pressure support invasively versus non-invasive pressure and TPs, as you see here on the side. And invasive versus non-invasive, there were no differences in terms of pressure time production in unloading, so to say. So with that, it should be preferable to use NIV. And if you look for the patient set, there are a bunch of patient data now on the market where we know from that it is efficiently used in COPD, and of course it is also usable in acute cardiopulmonary edema. However, if we come to the more severe states of hypoxemic respiratory failure, we got into trouble with non-invasive ventilation. Why is that? Well, coming back to this issue that we have to stabilize the alveolar spaces, we have to realize that the time that is needed to reach a lung collapse is rather short, and we heard that from Dr. Slutsky today. So there's within the first 4 seconds, or even down to 0.6 seconds are needed in order to see such a collapse. And with the intermittent application, such as non-invasive ventilation, we will not be successful to get these lungs here stabilized over time. So that's the reason why we are not that efficient in primarily hypoxemic respiratory failure patients. And as you see here by this nice study from Antonelli from 2001, the more severe the state, so the more time you need to get the patient back to normal, the more time you need him on a stable FiO2 and thus gas exchange, less high is the chance to succeed with non-invasive ventilation. So that's one point, the clinical status of the patient. And the second is the interfacing, the technique which might cause a failure. And as you see here, these guys, they didn't want to look like that, although it looks almost like that. In these situations, you don't have synchrony at all. And that is a severe problem in non-invasive ventilation, and you can't avoid triggering delays, off-cycling delays with non-invasive ventilation if you are on a pneumatic trigger. And that is nicely shown here by this Vignon study from 2007, where you see that whatever ventilator you choose, there are delays that reach up to 200 milliseconds, and thus you have a certain amount of inspiratory work in order to even trigger the ventilator, and you might even get worse if you have a non-invasive mode with leakage compensation. So, and the consequences of poor synchrony of the ventilator and the patient are increased work of breathing, respiratory muscle fatigue, deterioration of gas exchange, decreased patient comfort, and increased use of sedatives, and this altogether leads to non-invasive ventilation failure in these patients. So that is the ventilator, and then of course it comes to the interface, which also has its place. So they are not equally effective if you look at the helmet compared to the face masks, and that has also to be taken into account. But I don't want to go into detail on that in order to stay in time. And thus I now come to the conclusion of the introduction. The causes of non-invasive ventilation failure are the selection of inappropriate patients, progression of the underlying disease, and then you have the problems that are related to the interface, to insufficient ventilatory settings, or to an inefficient ventilator. And what we will hear now in the next talks probably is that neural triggering will help us to at least solve some of the problems related to non-invasive ventilatory failure. So, and with that, I'm through with my talk, and I like to go to the next speaker, which is Jennifer Beck. So your stage.